Now, I have to talk to parents about this because some parents say, well, they can't have ADHD because they can play video games for hours and focus. And I said, well, what does a video game do? You have lights, noise, action. I said, the best teacher can't be lights, noise, and action for 8 hours a day. The teacher's never going to be able to compete with a video game with it.
True.
So it's the issue is that in this setting where you have to have some ability to focus for a short term time that's age appropriate, they're unable to do that at this time.
Today on the show, we're joined by someone whose work sits at the heart of mental health care in our community. Dr. Michael Ingram is the Director of Behavioral Health at Great Lakes Bay Health Centers. Born and raised in Detroit, went on to study at Michigan State University, and later completed his psychiatry residency at Wayne State University. In 2016, he became a fellow of the American Psychiatric Association. And since then, his work has focused on expanding access, breaking stigma, and meeting people exactly where they are. We're talking everything from stigma and burnout to autism, ADHD, and the opioid crisis, and what real healing looks like. Thank you, Dr. Ingram.
Oh, thank you very much, Alexandria, for this opportunity to talk. So I'm really looking forward to it.
I'm looking forward to it, too. As I said, off camera and everything goes, on my timeline, there's been this huge conversation around ADHD, around autism, and then just also in our community, we're seeing such a crisis with this opioid epidemic. Okay. So I'm ready to dive in.
Okay. Well, if you don't mind, I typically like to kind of get a little bit of background about the types of ADHD. Now, there's basically three types of ADHD. Okay. ADHD inattentive type, ADHD's hyperactivity type, and ADHD combined type at this time. Now, it doesn't really make any difference in treatment. So sometimes a patient will come in and say, well, I have the hyperactivity type. And I said, okay, does it really change anything at the time? So three types with them. I do just want to give one caveat. With ADHD, we do see it more commonly in boys, okay? But ADHD inattentive type is probably seen more in girls, and often girls are overlooked. So just think about hyperactivity for young boys. They can't sit in their desk. They're crawling on the floor. They're jumping around. You have the teacher's attention. But you have inattentive type where you're just sitting and daydreaming. You're staring out the window. You're not listening. The teacher may not focus on you at that time because you have someone who really requires a lot of attention. So often girls are underdiagnosed or diagnosed later because you don't have the hyperactivity component to it.
And so I think that's fascinating because when you talk about boys being diagnosed, or at least I think or feel that we're seeing such a high diagnosis among boys. But what if that's just their biology, testosterone? Is that a thing where they're just a little bit more hyperactive? Maybe the education or the learning style isn't for them. What do you say to that?
Okay. Well, first of all, ADHD and the name has changed.
Okay.
One point is hyperkinetic syndrome at this time then. So we talk about symptoms have been present, documented for well over 100 years at that time. Now, there are some concerns about the diagnosis being made more commonly, but that may be multiple factors. So number one, school systems are now become much more stressful. Now, what do I mean by that? 30, 40 years ago, kindergarten was play. You didn't have to know your name, you didn't have to know alphabet, you played with blocks. Really, kindergarten really was kind of a playtime. Nowadays, kindergarten, you expected to know your name, spelling, possibly reading, being able to sit at this time then. So we've seen this shift to that there's a higher demand for our children right now at the early ages. So that's part of it. Number two, we do have issues where the school system has become much more competitive with it at this time. So I've had patients tell me that, I'm working on daycare for my baby that's not been born yet. I said, well, what do you mean? She said, it's really competitive. These good daycare programs, they got a waiting list that I got to start now. So, competition is starting early on. And that adds pressure to it at this time. So we do put our children under more pressure at this point then about academic performance at the time, and I think that contributes to it at this time. So it may have been there, but what we're seeing, these other pressure may leading to this being diagnosed more frequently at this time. So we may not have looked at it as much when it was old, when they were in the past with it, but with these other pressures, I think what we're seeing is being diagnosed. So maybe there's just the diagnosis have gone up because I think these other factors in.
So I feel like what I'm hearing, though, is maybe there should be some type of change to also how we school our kids.
Absolutely. But that trend is not going that way with them. Now, you've seen some cases, like for example, the Montessori system, a lot more flexibility, but that's an expensive system. Okay. And many parents can't afford that. Many parents, the first exposure will be kindergarten at that point then. So there are other ways of doing with it, contributing. And the success rate of Montessori is actually quite comparable. Okay. These are smaller classrooms at this time then, so you have that issue with them. And I don't really see this issue with most public schools saying that we're going to go with smaller class sizes. It actually seems to be the opposite. The teachers will tell you at this time is that, listen, we have to do with more kids. We have to do more with less. At this time, there's more documentation, more regimen. One teacher said to me, the documentation and the things that I have to do now is worse and worse every year. So that's may push me into retirement. And I said, well, I hope paperwork doesn't push you to retirement, but that'd be a shame.
But sometimes it could be if it's more stressful. It sounds like it's more stressful on the paperwork versus the children.
Absolutely.
Yeah. So that was a question that I had because I wondered, should there be a conversation around how we educate children? I mean, again, you see little boys. Why are they being diagnosed when it could be their testosterone and they just need to get the energy out? Well, maybe we need to change or separate. I don't know.
Absolutely. But you know what? The diagnosis is age-related. So I tell parents is that there certainly is, we do not expect a 5-year-old to be able to sit in class as a 15-year-old. So it's not an issue about boys just having more testosterone with them. But the teachers will tell you is that when we talk about ADHD kids is that with that age, these children are standing out. So when you talk about inattentiveness, the teachers know the attention from a 5-year-old is not going to be a 15-year-old, but there should be some attention at that point then. Now, I have to talk to parents about this because some parents say, well, they can't have ADHD because they can play video games for hours and focus. And I said, well, what does a video game do? You have lights, noise, action. I said, the best teacher can't be lights, noise, and action for 8 hours a day. The teacher's never going to be able to compete with a video game with it.
True.
So it's the issue is that in this setting where you have to have some ability to focus for a short term time that's age appropriate, they're unable to do that at this time with them. So it's not just boys being boys. It's really issues that with the norms, and most teachers will tell you is that 90% of the boys can do in this class. This one boy is having a problem at that time with it. So they're not saying all the boys with it at that time. So it does really stand out with them. And it's not just the hyperactivity with them, it's other things. So, there's a whole diagnostic criteria about listening at that point then, okay? Distractions. So ADHD, one of my key issues, I always ask parents that, okay, what happens when you're trying to get them to do work at home? And the parents say, I can have them sit down, they'll do the homework for me. And I said, okay, well, what happens if you leave? Well, if I leave and go out the room, and if something comes across the time, he's distracted. So what happened is, as long as you have someone standing over you, well, pay attention, I'm doing fine. Yeah. But the second you walk away, they get distracted with him. Now, if you got 20 to 30 kids in your classroom, you can't stand on the desk that whole over that one kid. So the distractibility is an issue with it at this time. The organizational skills with it. I ask often at parents and say, they're not doing the homework. What's going on? Well, they lost the homework when they brought it home. They can't find a pencil. My favorite example is that I saw them do the homework. We did it at home. They lost it before they turned it in. And you don't get credit for just doing it at that time with them. So those are all factors that kind of go along with it with the diagnosis at this time. So it's just not boys being boys, it's actually other things in the diagnostic criteria.
Okay, so now that you're on the topic, when you talk about being inattentive, what does that look like? And you said more girls may be diagnosed with that. So what does that look like?
So kind of inattentiveness is that they're not. Now, some parents say, well, they're daydreaming. I said, well, daydreaming means that they're internalizing things. So the teacher may be talking about a subject, but if you're thinking about, well, what's the weather like at time? What am I going to play with at this point then? So you're not focusing on what's going on. You're kind of daydreaming about other things that go along with it. So in the classroom, they're kind of sitting quiet at that point then. Yeah. They're not causing any problems with them. But if the teacher calls on them, you don't know what answer to give. You don't know what topic is at this point because you haven't been paying attention with them. So you see that more commonly in girls because they're not causing any behavioral problems. And if you're not able to listen in the classroom, sooner or later it's going to catch up with your homework, okay? I've missed the whole assignment at that point, and now I have to do homework. I don't even know what we're talking about at that time with them. So what you see that you start having problems with, and they're missing information to complete things.
So, okay, so this makes me think, and I don't know where I heard this at, but it was some culture where they do more concentrated education. So a child may be more inclined to be, a math whiz or English. Could that be the case for kids like that with ADHD? Maybe they're just not focused because they don't like this material, but maybe they may be more focused or engaged in another portion of education.
So I still think you're going to see things kind of a bell-shaped curve.
Okay.
So you're going to have kids that are outliers. You can have kids who can pick up the most minute details without any difficulties at that time. Hyper-focused at this point. They'll tell the teachers that, you know what, you changed your lipstick. Now, how many kids can remember what the teacher's lipstick? I mean, very astute at that time then. So very focused. And you got kids who can't focus at all. I mean, are you really my teacher at this point then? Who are you? I don't remember your name. But the majority in that bell-shaped curve were able to kind of focus on these things where they have to demand their attention at that time. So when we talk about these situations, for example, some cultures have a much less of a demand in elementary school than we do in the U.S. Japan is, for example, that less of a actually, even when Japan, when you talk about the college system, the college exams in Japan are hard. But once you get into the college in Japan, it's hard to get kicked out. I mean, to be honest with you, they try after try. So once you pass the exam, you're okay with it. So what we see is this kind of unstructured learning with it. This pressure builds up. Once you kind of get into college, the pressure kind of lessens at this time.
That's
So
interesting.
you do see that, there's some merit to that at this point then. But when we talk about our teachers here, that the teacher is simply saying that within the norm, and they're knowing the norm. They know that, listen, I can expect my 5-year-olds to focus for 10 to 15 minutes to tell what the homework assignment is, to understand what to do, to ask questions, and then do the assignment at that time. And they're not having them sit down and do math problems for 5 hours. It's just what they expected will stand out at this time. So they'll easily tell you that this is not what they're seeing in the other children. So it's not just an issue that, this kid has a particular type of learning. It's what that norm is. So my other example is that, there's times in which you have to focus. Okay, my classic example is that when our children are crossing the street, we want them to kind of focus. Okay, I mean, this is the time to say, let me look both ways. Okay, so let's focus on this at this point. Then, okay, our car's coming. Is the light with me at this time? Is it safe to cross? We don't want to say to cross the street and say, "Oh, I'm not looking around. I'm not paying attention with it." That's risky behavior. So there's times in which we want them to focus, and we should expect them to be able to focus during this time. Other times it's probably less important. So when that's coming up, the teacher's saying that's outside the norm, and I don't think it's just. Kids kids have different way of learning. You're going to just see that some kids are going to be at the extremes at that point.
Okay, I got you. So, given these 3 different types of ADHD, is the best diagnosis is it to prescribe medication for those children, or do you find some type of other treatment plan for them?
Okay. Well, first of all, I always tell the parents that they have the final say. Okay, so I don't want this to ever be an issue that we're telling you what to do. This is your child. You have the final say. Now, I sometimes get kickback from teachers. I've seen kids who come in for assessment where the parents say, well, they were told if they can't get them on medication not to bring them back to school. And I said,
wow.
That's not really the teacher's role. You have to feel comfortable doing this at this time. So the parents have the final say with them. And what we typically see is that before they get to us is that teacher most time has made some type of modification. So one modification is that they're distracted. Let me move them to the front of the classroom. Okay, that helps. Okay, another modification with them. If they're in a peer group that seems to be talking a lot, let's break up that peer group at that point then. Another modification, give them structure at home with them. So in the computerized days right now, where the parents can actually go home, go online and say what their homework assignment is with them, that's a way of kind of following with them. So they've often tried these kind of behavior interventions. I encourage the parents to do that too with them. So give them a quiet place to study, give them a quiet place to work at home with them. But even with those parameters, if they're still struggling, medication options should be looked at.
Okay, but it's not necessarily pushed, like you said. It's for the parents.
It's always the parents' decision. I have some parents who I said, well, my goodness, they're struggling in school. They clearly meet the diagnostic criteria for both categories at this point then. But you have to decide if you want to treat it. And some parents say, I'm just not ready. I want to try some other things with it at this time with them. I'll give you a story. I have a physician, a colleague of mine, who said, well, the kids said the teacher said my son has ADHD. I don't think it's a problem with him. He does the homework for me. Now, he's very regimented. When he's sitting down and having to do the homework, he'll do the homework at that point then. And he said, it can't be that. He went to school one time and checked in on the kid's classroom. And he said, my mouth fell open. He couldn't stay in his seat at this point then. He would roll over the classroom. The teacher would get behind him and point to the desk. He would pay attention for about a minute at that time. As soon as she walk away, he would start looking around at that point then.
Oh, wow.
So for him, he was very structured and would do response. But in a classroom with 20 other students at that point, then he was not with them. And I just reminded him, I said, well, can you go to school every day and direct him? He said, I can't. I said that we need to talk about choices because even though I think he's a little bit afraid of you, he'll do it for you.
Yeah.
But in the classroom setting, he's not able to do it with what he's expected of the teachers at that point. So, but it's always up to the parents, and we try to respect those wishes. And I never tell a parent you're going to have to do it my way. I mean, I tell, listen, if you want me to just pray over it, let's pray over it. We can reassess things, but I want you to be on board with it because if you don't not on board with it, the kids are not on board with it.
Yeah.
Now, we do have some special circumstances. Unfortunately, split households, if the parents are not together, it
That is
becomes an
difficult.
issue. It really becomes an
It's
issue.
very difficult.
Now, I have to just tell parents by right, I only have to have one parent agree. So, and what will happen is one parent say, well, I didn't agree to it. I say, I understand that, but I cannot basically say we're going to treat only if both of you guys agree. So if the symptoms are there and one parent agreed, that's enough with it. And I'd like you to come in and tell me why you disagree with it so I can kind of give you my explanation with it at this time with them. But I only really need one parent to agree. And we've had court cases where they say, well, I'm going to go to court and the judge with them. I said, you can. We've done this. This is not our first rodeo with it. So I need one parent to agree. I said, it's a very formal diagnosis criteria with it. And I also remind my colleagues, said, don't skip. So a diagnosis of ADHD requires you have symptoms in at least 2 locations, at home and typically at school.
Okay.
If you're only seeing ADHD symptoms at home and not seeing it at school, that's probably not ADHD at that time. If they're seeing it at school and not at home, maybe something else is going on at the time. Often kids may have emotional issues going on, but it should be in 2 locations. So it's a very formal diagnostic criteria at this time. But once the diagnostic get met, you have the option of offering treatment. And if one parent agrees, that should be enough for the other parent if they're comfortable with it.
That's very fascinating. I mean, of course, I'm not a doctor, so I wouldn't know the criteria, but that's really fascinating that you look at both areas. And so I think that's fascinating, but also bringing up the split custody, that is a huge issue because we are seeing more families being separated and then also just children being raised by different people, their grandparents. So there's so many other caregivers in their lives. Very fascinating. But I'm happy that I'm just happy about the medication, hearing that conversation that it is their final say.
It should always be the parents at this, because they are raising a kid at this time, but children are very perceptive. If they pick up that you're not happy with this, they're not going to be happy. So you want really the kind of parents being on board with them, and that means taking the time to get them on board with it, because the diagnosis is not going to go away. So this is not a case that, oh my goodness, we didn't diagnose them at age 5 years old. Age 6, we're not going to have ADHD. It's not going anywhere. So they wait a year. It is not going anywhere at that point. Wait a year is not going to change anything.
So what about adults? Because I feel like more adults are now going to be are being evaluated. So what happened? Were they inattentive this entire time, and now we're looking at these TikTok trends? And
so that has kind of changed things. So even with children, we probably got about 50% of the children who are not diagnosed or treatment. So that means you have a large percentage of adults may not have been diagnosed when they're younger. Now, the diagnosis of adults is a little bit more difficult because, in many cases, I can't get access to records in kindergarten. I would love to. And I've seen cases where parents have called up and said, kept records, said, you brought in the kindergarten report card. The teacher said you wasn't listening, you couldn't stay at your desk, and you had to remind them things at that point. Then I said, sounds like you had some problems back then with them, but we can't always count on that. So when you talk about diagnosis of ADHD in adults, you typically can't get information in a school setting because you don't have the records available. Now, once in a while you can. There have been some adults in which they've actually had testing that was easy to do with them, sometimes report cards with them. Sometimes you could actually, if their parents are available, you can actually have the parents talk about ADHD symptoms, have the comparison complete one with the time, but it's harder. Now, what that means is this becomes debatable. I have some providers that simply say, you know what, I don't believe in adult ADHD. If the diagnosis said you have to have symptoms before age 12, and if it's after age 12, it doesn't exist. And I said, well, that may be true. That's what the diagnostic criteria was. But we do sometimes see it not being diagnosed with adults. But because you can't go back and get school records, it makes it more difficult. So I don't feel that every adult that comes in and said, I was online, I feel that the ADHD questionnaire, I have ADHD, give me my medication, meets the criteria for ADHD. So I think there's a process with it. So there's a wonderful article from American Family Practice. And this is what I actually teach our residents and our attendees to say. They really emphasize this issue about adults with ADHD. It's a multiple step process to get the diagnosis. And that the patient should be told that this is not something that's going to be diagnosed in one visit. So you can't walk in and say, I completed questionnaires. What's my medication? So first of all, you should make some effort to get ancillary information with them.
Right.
So even though I've had some people say, well, they said the school records don't exist. I said, you would be surprised how durable school records are. They've gotten school records back from 50 years.
I am kind of curious because all the schools I went to, they're like all closed. Building is demolished. So where are my records?
But they may still have the records at that
Okay.
point. Some schools have digitized information at this time. And I don't guarantee you'll get it, but you should at least try. So get answer information. Other people have seen the patient. I've seen pediatricians document symptoms. Patients could not sit still in the exam room, had difficulties with them. That could be a source at this point then. Make sure that you're not overlooking anything else. So if adult is having ADHD symptoms at this point, then are you dealing with depression, anxiety can have impact on symptoms at that point then. So this whole issue about trying to get some outside information, it's not the best source of information, but I have spouses fill out a ADHD questionnaire because spouses simply say, well, I don't know how they were when they were younger, but they can't pay attention now. They're losing things, losing the car keys. They forgot to do X, Y, Z. Spouses can document it. But some effort to get answer information for adults, I think, helps with it at that time with them. There's a place for my stand for computerized testing at this point. Then we use the Connors and the IVA computer testing for ADHD. And what it does is kind of helps. Now, it's not required. I don't want anyone to say that you have to have a computer test for ADHD. You do not. But when you don't have ancillary information, the computerized testing kind of gives you more information. These are kind of time tests, looking at attention and concentration. That's kind of a great with them. So it's a little bit harder with adults, and I think you need to take an added step because the medications do have some risk with it. The stimulant medication has some abuse potential at this time. So you want
when you say abuse potential, what does that mean?
So basically, they're not using it appropriately. They're either taking more than they should do or divert them at this time. So you have to be a little bit more cautious with adults with them. But I do feel it's worth it to take that time to get the additional information. And then if they meet the criteria, certainly treat appropriately. Some adults didn't meet the criteria. I've had times in which I said, you know what, we simply can't really document symptoms before age 12. You have some symptoms. I don't really think it's formally ADHD, but you do have other things going on. Maybe look at some other treatment alternatives at that point.
Okay. And at that point, are you referring out? Is that a therapy? What does that look like?
No. The treatment could be therapy, could be other medications, options with it. If I had my choice for adults, the gold standard is really neuropsychological testing. These are 3 to 6 hour tests. They look at IQ, cognitive functioning at this point, then time tests. So by far, if you simply are not really sure, that's the way to do. But
is that testing available in Saginaw?
Yeah, actually, Midland has a couple of doctors in Midland do it at that time. But it's very expensive, number one. So insurance have to cover with it. It's time consuming. If it's going to take 6 hours to do the test, they're not doing 20.
Well, if you want answers.
Yeah, and they're not doing 20 a day at that time. So that with them, but that's really the gold standard of someone I'm not really sure about at that point.
Okay.
But it is not required. It's a clinical diagnosis.
Well, very fascinating. And thank you so much for giving us that information around ADHD. So if anyone's out there who may think their significant other or family member may have it, definitely reach out.
But for adults, remember, it's not going to be made in one appointment. Okay.
Not one appointment. And that's okay, though.
Right.
That's okay. I would rather that it's more appointments so you can get the right answer versus someone just handing off some medication or anything like that. So I have to ask you, we've been talking so much about ADHD, but you have been a psychiatrist for decades. When did you know, what was the aha moment for you to dive into this work?
Okay. Typically what happens in medicine is who you're exposed to. I was exposed to a family doctor, and I thought all doctors were family doctors at that point then. So, you go through medical school and you said, okay, I'm going to do family medicine, internal medicine. And I didn't know anything about psychiatry. My second three rotations before I ended, I had his mandate of psychiatry, and I never had I had this professor named Gerald Osborne. I think Dr. Osborne may still be around, but Dr. Osborne was just so dynamic. In fact, I didn't realize I'd become Dr. Osborne. He was a runner. I became a runner at this point. He was enthusiastic about the field with him, and he just made the field alive. And I never forget he said one thing about it is that, now I'm not comparing about other specialties. He said, surgery, if they see one appendectomy, once they cut them up, all appendectomy is the same as a complication. There's no big issue. He said, it's never like that in psychiatry. Each patient is an individual with a story. So the diagnosis may be the same, but how it affects that patient as an individual. And the stories are fascinating because this is what people are about at this time. So you're not a diagnosis, it's how you handle that diagnosis, how it has an effect on you with them. So he brought the field alive to me at that time with them. And I started looking and I said, oh, wow, I never thought of this. Particularly with mental health, you don't have a lot of exposure with it. My mother had not had a lot of exposure. My mother simply said everyone is either crazy or drunk. She was kind of right because we have a lot of substance use is relatively common at that point in, and a lot of people can have mental health problems with it. But that was my view. They're all either crazy or drunk with it. But to have them bring the feel alive for me is great. And as you kind of get into it, is that listening to patient's story makes us alive. So, I have when people say, do you get tired of listening? I said, no, each patient is different, okay? What's going on with their dog? How's the depression affecting them? How's with their job? It is so complicated. It becomes the issues that we have to have. We want more time with them, but it's wonderful because you interact with patients and you actually listen to their stories at that point then.
Yeah. And you said that on the phone, I think, when we talked, and it's about that listening component. I forgot what you said. Can you
each person has a story. So we want to listen to that person's individual story at that point. So they pay us to actually listen to people talking at that point then. So I'm not saying other specialties don't do it, but in many cases, if you're paid for a procedure, you don't really care what they got to say at that point. But I'm actually paid to listen to them talk.
Yeah, that is. I love that. I'm always curious about how do people dive into their work, and so it just sounds like it was another professor that you met.
Absolutely.
And now you're doing the same thing now with the residents that's going through Great Lakes Bay. That's awesome. This episode is brought to you by Great Lakes Bay Health Centers, where everyone deserves access to quality health care, and no one is turned away based on ability to pay. Learn more at greatlakesbayhealthcenters.org. Okay, so we talked about ADHD. We didn't really get into autism. Okay. Now, I read an article on Johns Hopkins, and it said that the cases for autism is also rising. In over 20 years, 300% increase of cases. So is it the same with ADHD? Is it the screen time? Is it genetics? Is it just the environment? Okay. What is your perspective on it? So
there has been some changes with the diagnostic criteria of autism. Now, when I train children were presented with autism if they have Asperger's syndrome, which is kind of a form of autism. Girls would have Rett syndrome at this time. You could have perverse developmental disorder. So what happened is that with the change, that it's become autism spectrum disorder. So we've kind of rolled a lot of things into that diagnosis. So that's one component too. So a lot more things with it, which is good because in many cases, the different these other diagnoses didn't really change the treatment at that time. So the diagnostic criteria has broadened at this point then. Okay. That's number one. We do have a genetic component to autism, but it's not one-to-one. So I know parents will simply say, well, I'm worried about it because my uncle had this. Is my kid with them? I said, even if both parents have it, it's not a one-to-one transmission, but it's just a higher rate at that time with them. You have the genetic component, which doesn't change. We can't change. We can't do anything about our genetics at this point. I mean, I would love to say I came from a Kenya background. I'm a fast, long-distance runner. It's just not going to, I can't run as fast as they do at that point. So my genes are not going to change with them. And I don't think my training is going to change with them. So we can't really change the genes. Environmental factors, we don't really know, but it's not enough at this time to say that's a definite cause with it. So we have the issue about vaccines. Absolutely. No clinical data to support this at this time. Now, what happened is that you see case reports. That's not the same thing as clinical data that you want to basically guide the nation on at this point then. So I could have a clinical report is that I ate a certain food, had an allergic reaction. Okay, that's rare at that point then. Does that mean that particular food is bad? No one should have that food with it. So you have to be cautious about that. Yeah. We also are talking about, when we talk about autism, is that you have more issues because of this broader spectrum, is that more kids are being diagnosed early on with them. So we had to kind of what I would call autism is kind of late stage 1, 2, and 3, and stage 1 is kind of the most severe case at that point.
So on the spectrum, it's 1 to 3. Is that what it is?
Right,
okay.
Right. So the more severe cases were easy because what happens is they have more classic features with it. So autism, you're basically going to see areas and function in 5 areas. So one of the areas is communication. And parents will tell you early on is that with autism kids is that, they're not communicating well. I'm talking and they don't look at that point then. Or they're not interacting at this point then. Or not using language. They're doing a lot of pointing. So that's a risk factor early on with them. They talk about social interaction at this point then. Now, social interaction is kind of subtle with it, but what I typically ask parents to say, well, how are they getting along with other kids? There's no rule book for kids. So they don't say, well, this is rule number 1 to make friends, but they pick up on how to get along with friends. If someone throws you the ball, you throw the ball back at that point then. If someone looks at you and talk to you, kind of look at them at this time. So they have problems making friends with them because they can't miss these interactions with it at this point then. They have a past history, what we call repetitive behavior, restricted behavior. Repetitive behavior presents many ways, but my classic issue is hand flapping. And we don't know why they're doing this, but sometimes kids with autism will just have this issue where they're doing their hands. I have a patient where he'll just do his hair like this repetitive.
Yeah.
So they have these kind of repetitive behavior that kind of stand out at that point. And the parents will notice that. Now, it could be anxiety, it could be stresses. For my patient with autism, when they're under stress, I see it come out a lot more than they sometimes have these kind of restricted interests. Now, I have some parents say, well, they're just kind of a nerd. I said, well, probably a lot of us are nerds at this point then, but what is the interest? It's kind of interest that probably just stands out. So if someone told me they memorized all the players on their basketball team, I said, oh, that probably is not with them. But someone tell me that I memorized everybody's shoe size on basketball at that time, which patients have done at this point then.
Wow.
Or
You
at
had a patient that memorized the shoe size.
shoe sizes because that amount of detail. Or a patient who memorized everyone's license plate in the parking lot. And I would say, he said, who's blah, 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 blah. I said, that's your car? I said, yes, with him. So,
he needs to work in a crime division.
So,
police.
I'm not sure what the purpose of doing that, but, just kind of these hyper-focused areas, you kind of stand out and you're simply saying, well, I don't think most people memorize everybody's license plate when they kind of come in with them. So those type of things stand out. And not only that is that they want others to be interested with it. So I can just guarantee you for a 6-year-old, your friends don't care about the license plates. So you're trying to get them engaged about license plates and they don't have any idea with it, so they don't want to talk to you at that time then. You get this history of patients saying, families saying, they're just very sensitive things. A classic is that loud noises seem to bother them. I have a patient come in who's a parent say, I have to put headphones at this time with them. Touch. Parents say, itchy clothing, sweaters, it would just put them into a rage at that time with it. So you get those type of factors that kind of go along with it at this time. So these kind of things stand out. But then you have kids that are lower function, higher function. So the lower functioning kids at the time would easily stand out. But the kids who have part of the spectrum at that time with them, we're probably seeing a higher increase in those because we're diagnosed with them. So if your communication skills are okay, you can kind of get by with them. Autism kids that on the higher range are very bright at this time. They can read the room at this point. And so they'll say is that my parents seem to get upset when I talk about license plates. I better not talk about with them. I'll find someone else with it at that time with them. So they're functioning because they can adapt. And what happens is that we're picking up on them because they're having other areas with them. So it's great to simply say, I figured out not to talk in school because my teachers get upset when I talk about license plates with it. But I'm having problems in my classroom because the kids don't interact with me. So it's very frustrating with them. So we're picking up these higher functioning kids at this point then, which we typically would not treat or see when they were younger at this time. We saw the more severe cases with lower IQs and those type of things with them. And, I have colleagues who simply say, you can choose you can do okay. I'm not picking on anyone, but if someone says that I'm an engineer, I really don't have to communicate with anyone at this point. Then once a year I have to give a report. That's the most stressful thing in my life. The other times we can all communicate in email with them. So you don't really have to do any social interaction with them at this point then. He writes fairly well, so there's not a problem there with him. His only problem is that he has to do the presentation at this time with them. And he has some autistic features at that point then. Doesn't like people at that time. Has problems with communication, problems with relations with them, but he functions well at this time. So what we see is these kind of higher functioning kids, adults, children going to adults, being picked up more frequently than we did in the past at that time. So I do not feel at this time that we have enough evidence to say this is because of the red dye number 3, the environment, process, but we just don't know.
And that is definitely one of the questions I had wondered. And I know, like you said, with political information that's been out there, trying to diagnose it with vaccines and this and that. So,
and I know parents are scared about it, but in many cases, I tell parents is that I have parents came in this week simply saying, well, I'm going to change it. I think that the autism may be related to food. I'm going to change and put them on a food diet where it's food restrictions. And I said, I can't tell you what to do, but if you're going to spend effort and energy, time and money on it, I said, focus on a well-balanced diet, okay? Yeah. More fruits and vegetables. So you don't have to simply say, I'm going to get rid of all the grains. I'm going to get rid of the wheat gluten. Focus on the well-balanced diet. So if we can get the child more exposed to that, we'll do much better than simply saying, I'm going to cut out gluten at this point then, which is expensive.
Yeah. Well, this is really good information, and I hope everybody's receiving that.
Mhm.
So before, I still have more questions, but just let them know where they can find out more about you and the work you do and where you're at.
Sure. So I'm at Great Lakes Bay Healthcare Center. We have multiple locations in the state. Our primary office of behavioral health is in Bay City, in Saginaw on Davenport at this time, but we also have locations in the Thumb area, have locations in Shiawassee. At this time, we have locations in Carroll at this point. Then there's a contact number with it. I don't want to give it out because we're at a different location at this time, but my main number is 989-922-5700, and we're more than willing to help. I've been blessed, and I do really feel it's a blessing to kind of work with Great Lakes Bay. We serve about 50,000, a little over 50,000 patients in multiple counties with it, and we see everyone, which means for the first time in my life is that a patient needed need. I didn't have to simply say, well, what insurance do you have? Are we going to run into problems? So I have a colleague who called me one time, and he said, I'll never forget, he said, I'm not doing well, buddy. I need help. And he had some problems with the relationship. He has a problem with his job with him. And I said, and he said, I don't have any insurance. I sent him a 401. I said, call this number. We will help you. I said, it's not an issue about saying what insurance you have at that point with them. And I haven't been there other places. I've been places at this time that said, I can see if we can see you, but I'm have you talk to the billing officers. So we see everyone at this time, and we try to certainly do the best we can. But there are other resources in the community too.
That is awesome. And that's really good to know. I was just talking to someone earlier, actually today, and they said, I need to see a doctor, but I don't have health care insurance.
Well,
so that's really awesome.
Please inform them that these services are available. I know you told me the answer, but let me just say one reason why I think this is so important that we get health care. Causes of death, and we kind of got 5 big causes of death, okay? Heart disease, okay? Cancer, accidents at this point, then strokes, and basically pulmonary problems. Those first 2, you can't pick up on unless you're doing screening and following up with them. So hypertension, you don't say wicked one day and say, oh, my blood pressure is high. No. You have to be seen and screened for it at this time with them. So they have the greatest opportunity to make an intervention. We got to know about it. So you have to see someone. So I see the extremes. I'm 18 years old. I'm happy, strong as a horse, nothing wrong with me. Why do I need to see a doctor? Simply say, well, even 18-year-olds can have problems with it, but you want to have a relationship with someone because you want someone to monitor you over time to pick up on things at this time. So that's why it's so important. And I try to preach this in heaven that have some type of primary care doctor. The ER cannot do it because they don't see you long enough with it. So, and we can reduce the morbidity and mortality of these things, but we got to intervene early. That means you got to screen them, people at this point.
Yes, you're speaking to a choir over here. Yes, no, that's really good. And I know you kind of brought this up, but a couple weeks ago there was a luncheon and there were healthcare CEOs that were talking. And they were talking about how, insurance is going up and people's premiums, and they are a concern. And this is also, in that dialogue, there was also the conversation around crime could increase. If people aren't going to the doctor, now you have these other factors that's increasing, especially around mental health. If you feel like you can't pay your bills, you can't go to see a doctor, we're going to see some other things increase. So can you talk a little bit about that? Like what's happening politically as far as our healthcare? Can you talk a little bit about that?
Well, we are really concerned because as we start basically seeing changes in the American Affordable Health Care Act at this point, then less people are going to have insurance. So what happens if you have less insurance at this point, then it becomes kind of this snowball. So the first issue is that if you can't get basic preventive care, you're only going to get care when you're in a crisis with it. So high blood pressure, great medication to treat, good response rate, lowering the comorbidity mortality. But if you don't get that treated, now you have a risk of cardiovascular disease with them, which is much more difficult to do. So if you had a heart attack and have to get a stent at that time, then thousands of times more expensive with it at this point. Then, now what happened is that you had to wait until you were having a severe symptom to go into the hospital to get that done. So what we've done is we talked about something that could lower the risk, now having to have the expensive procedure with it, or have the chance of a procedure. Now, in the hospital, in the ER, they have to treat you, but now you have no insurance. Now, what does that happen at that point then? So the ER has to treat you no matter what, but if they can't get reimbursed, in many cases you're not. So if you're not You don't have insurance. Your job can't afford it. You're probably not going to be able to afford an ER bill that time, which means they're going to harangue you about dealing with that. But most likely, they may not collect. So now the emergency departments are not doing well because they don't have the insurance that's paying with them. Now, if you lose emergency departments at that point, then it becomes a strain on some hospital systems with them. And our hospital systems have basically consolidated. It used to be every community had 4 or 5 hospitals. They all competed with one another for doctors. That's all gone. Most communities you only have 1 or 2 hospitals at that point then. And if they're under pressure from the emergency department, they can make a decision simply saying, listen, we can't afford certain services. There are communities in our area now that don't have any OB services at that point then. It's expensive. And if you're only having a few deliveries a year at this point, you can't afford it. So they shut that down.
Yeah.
Right there.
Wow. So, but what would this do to also the mental health community?
Well, with the same thing, if you don't have access to service, you wait until you're in a crisis at that time. So my classic example is that when patients present with onset of a schizophrenia, normally schizophrenia for males start about 18 to 25 with them. No, they have prodromal symptoms before they kind of formally diagnose with it, where families would notice, well, they're not going to school, they're not working, they become more agitated. That's really the best time to kind of intervene when you start having symptoms over for the first episode. Now, if you don't have any insurance at that point, then is that you typically will ignore this at that time, and you're going to wait to come into crisis. And the crisis of mental health is typically behavioral problems with them. So onset of schizophrenia, psychotic symptoms at that point, then you become agitated, paranoid, lock yourself in the house, call the police, et cetera. At this point, then now it becomes much more expensive to respond to treatment with them. And if you don't have insurance, the next issue is that once you got the diagnosis, how do you continue with treatment at that time with them? So all these kind of contribute to things. Now, you mentioned crime and those type of things too. All this kind of goes along when people are kind of desperate with it. So I just kind of remind individuals, you typically see a lower crime rate when the economy is doing better and people are doing well at this time. But when people become desperate, they start doing, and I'm not thinking this is a conscious effort with them, but people do make poor decisions because in many cases they do feel desperate at this time. And we always want to talk about being understanding with them. So, this is just a classic example with it. If you're struggling and simply saying, I don't have food to eat, are you going to tell me that I'm going to stay in my house and starve? Okay.
No.
All right. Okay. All right. So what happens is people become desperate. I'm not saying it's right or wrong with it at this time with it. So desperate times, what we see is that these type of things happen. And even though people say, well, they broke the law with it, I say you have to look at mitigating factors. One of my favorite examples is that during Hurricane Katrina, there was a picture, the devastation in New Orleans. So there's a picture of a father having a baby wrapped in a blanket. And someone's saying, well, what's going on? I said, well, you understand that he had to break into a room to get that blanket for his baby at that point. There's no stores. You couldn't go to Walmart and get that at that point then. So that was a crime, okay, at that point, if you want to look at it. But those are outside circumstances. And I hope when people look at these type of things, those are mitigating circumstances. Surely you wouldn't want your baby to be walking around on a blanket. If your baby wouldn't have food, you want to make sure you get food at this time. So you see those type of things magnified at this time when we see these type of economic uncertainties. And it is stressful and for families with it. And also we have to remember at this point is that we hope that the criminal justice doesn't over-respond. So some say the letter of law was broken, they should be punished with them. But it's really that the mitigating circumstance that we have to always look at. I hope our court system look at that too.
So listening to this, because I feel that there's this shift, right? I feel like we're seeing a shift in how people are responding now, and our inflation's going up. They feel like they can't afford health care insurance, and maybe they don't live in. Maybe they're listening to this conversation, don't live in Saginaw or nearby to even go to Great Lakes Bay. How can they find support or help or treatment?
Okay.
How can those people get access to anything? Okay.
So I'm not saying all out agency, but for our agencies, we will see everyone. So no, to be honest with you, we see a large number of people who are underinsured. Some insurance that is out, but we'll see anyone. So now that doesn't mean we're not going to try to get insurance for you. Okay, some people say, well, what does that mean? But we'll encourage you to get it. But we'll see anyone. So from our issues with it, we'll try to see anyone that comes into the wall, even with insurance. To be honest with you, we're not really here to see private insurance patient with them, but we'll take them too because we'll see anyone. So for Great Lakes Bay, we really keep the doors open for everyone. So there may be some people will simply saying, well, if you're seeing private patients at that time with them, why are you focusing on? They could see someone else, focusing on someone else. In case you see someone else, because they do have insurance. But I said, because we want to keep the doors open, that means you don't turn anyone away. I mean, it'd be easy to say, well, we don't take your insurance because you have private insurance, but we see everyone. No insurance, good insurance, bad insurance at this time with them. But we really have a mission to treat patients that are underinsured and no insurance. So I really encourage someone to get in. If you ran into a problem at a Great Lakes-based facility where they said they couldn't see you, please call me or call our medical director, because that's not our mission. We see everyone at this point because we know we can save time.
We're going to put that phone number at the bottom of this video so they can definitely give you a call, because I would hate for that to happen. But we definitely want them to come and get services for sure. So given the fact that you hear so many stories around people's mental health, all the work that you're doing, it takes on a real emotional toll. So how do you avoid the burnout in this career field? Because I hear a lot of burnout with therapists and also social workers. How do you avoid that?
Okay. Thank you for bringing that up with them. We as healers also have to kind of take care of ourselves at this point then. And I tell all providers, I think the key is burnout is that you have to have a life outside of medicine. So I'm an avid runner. I'm not the fastest runner. I never won a prize or anything, but I at least finished at this point. And so I'm an avid runner, great stress reducer. I believe we talk about the weather today. I run year round, okay, because it's never been too cold in Michigan that you can't run. Now you have to put more clothes on at this time, but I run year round.
That's good.
I spend time with things that I enjoy with it. So me and my wife and my family, we love to travel. Just the whole idea of planning a trip can be uplifting. Oh, what we're going to do for this trip at this point then. So try to time those type of things that you want. I really feel that faith in your religion has a part of our lives too with them. So even though we work hard, long hours, more documentation, more paperwork to be done at this point, then you try to balance those out. That typically helps with burnout with them. And I would tell all our healthcare professionals is that if you're feeling overwhelmed, it's okay to get help with them. We've had health professionals die of suicide at this time because they don't get help at this time. It's very, very debilitating because you would think that in medicine, they've all had some exposure to mental health. You can't get out of medical school without having some psychiatry at this point. So they certainly know about the resources with it, but for some reason they don't get help. Could be the stigma with it. There are other factors kind of going on with it. But I just tell our colleagues, it's okay to get help with them at this time and reach out with them because, we have to take care of ourselves at this point.
Yeah. And that was honestly like the first question I did have around the stigma. Why is there still a stigma when there's so many conversations online? I mean, so much has happened. We see celebrities talking about it, but there's still people who say, I do not want to see a psychiatrist or a therapist.
I think what some happens is that, for some levels, because they don't know a lot about it, you kind of run into this issue that it's all will. Just pull yourself out your bootstrap, push yourself up by your bootstraps, and you won't be depressed anymore at this time with them. And even when you talk about substance abuse with it, just stop drinking at that point. And the problem with them is not really will at this point. Then there's a strong biological component to substance abuse issues, to depression at this time with them. And you would never tell a cancer patient at this time, well, pull yourself out of the cancer at this point then. Just pull it off at that point then. So we don't treat it like other medical problems with it. That adds to the stigma with it. But we are getting better with it. When you talk about celebrities and other people bringing up, that makes it a little bit easier for folks to deal with at this time with them. But also we talk about treatment that are very, very, very effective with it. You mentioned that we talked about ADHD. The ADHD medications has a response rate of almost... So it's response rate to how well medicines work. A good response rate is 0.2 to 0.8. The ADHD medications have a response rate of almost 0.99. Very effective. Antidepressants have a response rate of 0.38 at this point then. The antipsychotics have a good response rate. So we got some great treatments at this time, which really should be encouraging people that we can. Now, I don't give a guarantee. I don't say everybody's going to do well with them. But we have some great treatment that I really feel can have an impact. And I encourage people to simply say, listen, we got a great chance of improving these symptoms if we know about it and start the treatment.
So what's the best way that a loved one, someone like myself or just any other individual out there, how can we encourage someone to seek help and make them feel like it's less pressure, make them feel less judged about it?
Oh, great. That's a wonderful topic. So what I tell folks is that your family members and friends much better than anyone else with them. So first of all, if you see there's a change or concern, point that out. People have a strong tendency for denial. Well, it's not that bad. I don't think depression is that bad. I don't think the manic symptoms is that bad. I don't think the substance use is that. So point out if you feel there's a change, number one. Number two, listen to what's going on. So it could be stressors that are going on then. And number three, you can't twist anyone's arm, but you can be supportive. And supportive saying that, listen, I'm concerned about you. There's services available with you. I think I would like you to do it, but I can't make you do it, but I can be supportive. You can go with the person at that time. You can find the numbers at this time. Now, let me be clear. They have to do some of this. Okay, so some substance use programs, you can't say, I'm calling for my brother. He needs a substance use problem. Can you help him? They have to respond with it. But you can kind of encourage them being supportive with it at this time with them. But people very long. And this whole idea about you, when something's going on, point it out to them. Because sometimes they think nothing's going on, that people don't know about it. But if you see that, say something. And that really makes a big difference. Someone shows that they notice different and that they care.
Yeah, that is so good. I love that answer. And I think I told you off camera that we had someone on the show who was is in recovery or is sober now, 8 years, but they had to make the decision, and they also had their loved one call them. So that's really good that you said that.
And that person should be commended because 8 years is wonderful.
Yeah.
Should be celebrated.
Yes, yes. So if you're listening, I'm sure she is. We celebrate you. And so thank you so much, Dr. Ingram. Is there anything else you'd like to share? Do you want to give that phone number again? How people can find you and connect with Great Lakes Bay?
I think I really enjoy the opportunity to talk to others about it. Thank you for the opportunity.
Thank you.
Medicine, psychiatry, is one-to-one. I see 20, 25 patients a day. I think your podcast is probably a little bit bigger than that. So anything that can kind of magnify the message, I really enjoy the opportunity. So thank you. The office number in Bay City is 989-922-5700. But there's a main number, which I'll maybe send later on. Okay. All right.
Thank you so much for joining us on the podcast.
Okay.
Thank you.
All right. Thank you.